Assalamu alaikum. Dr. Hussein, are you there?
I am
Great.
here. Can you hear me?
Yes, we can hear you. Can you hear us?
Yes, Khalid. Thank you, and thank you for the invitation and giving us the opportunity to present from Prince Sultan Cardiac Center. I have with me a prestigious and very experienced team, Abdurrahman Al-Mughairi, Bandar Shehri, and the anesthesia team, the radiology team, and the cath lab team. We're going to start our case. Can you go to next slide, please? Our patient is a 71 years old gentleman. He had TAVR in 2022 with evolute pro size 29. A year later, he had infective endocarditis, and he was treated for that. The course was uneventful, and he had no valve destruction. However, a few months later, he presented with symptoms of heart failure, and he was found to have severe prostatic valve regurg. His ejection fraction dropped to 30%, and his PA pressure went up to 75. His ECG is normal sinus rhythm. Next. When he came to us, he was in class 3 heart failure with lower limb edema, PND, and he had no stigmata of endocarditis, and all of his inflammatory markers were negative. The culture and sensitivity 3 times was also negative. Next. He was discussed in the heart team meeting with the surgeons, and his TS score is high, and based on his age and comorbidities and low ejection fraction, some RD impairment, the decision was to go for transcutaneous valve and valve. This is his baseline CT analysis, and you see he has large annulus with sinuses of almost 54 millimeters, good height, and sinusoidal junction also. The coronary height is around 15 millimeters. We don't have the images of the previous CT. His coronary angiography does not relate to heart disease, as you see. Only one is included. Next. And you see a good height. Sorry, go back. You see a good height of the coronaries, well deployed valve, and the sinuses are really large. Still, there is some sequestration, and you see the leaflets of the native valve. Next. His physical examination, he was in heart failure, and there is murmur of the heart. Other systems were unremarkable. Next. His echo showed severe aortic regurg. There's some variable leak, or at least moderate, and there was no masses on the valve. Ejection fraction around 30%. There's mild RV impairment with grade 3 diastolic dysfunction. There's global hypokinesia with some regenerating in the inferior wall with mild MR and moderate PR. Next. This is his current CT analysis, if you can see it. And you see the coronary height is around 14 millimeters. The valve measurement, the area is around 490. However, if you remember the previous CT, the baseline valve annulus area is around 700. So the valve is undersized a little bit. His coronary height is good. His sinutubular junction height is also good. Go, please. Anything you want to see from him?
If we could just pause here for a second, Hussein, because obviously this case brings up several questions that we need to address.
We can't hear you.
Can you hear us? Hello? Well, I'm just going to address a couple of questions based on this presentation to our panel here. And
please, next time, choose a good company for the live transmission.
You can't hear us? Hello? Hello, Hussein, can you hear us?
Conference room, you guys are on mute. That is why we cannot hear you. Please unmute yourself.
We are not on mute. Well,
No, the conference room.
Technical support, they can't hear us as
They
PSCC.
say
Could
you are
you
on mute.
They say we're on mute.
Did you hear us or no?
It
We
says
can
you
hear
are on
you.
mute, guys. Khalid, we cannot hear you.
Technical support, please. We need to be in contact with PSE. We can see them, we can hear them, they can't hear us.
Now we can hear you. I think there's an issue since we started with this live transmission. I think you should choose somebody with good experience to do that, please. Okay.
Can we just have a few minutes here, Hussein? Continue doing what you need to do. I'd just like to involve the panel here a little bit. So we're dealing with a early TAVI failure 2 years post-implantation due to bacterial endocarditis, and I have a surgeon sitting right next to me. So he's a relatively young patient, he's 71 years old, he's had endocarditis on a prosthetic valve. The surgical dictum has always been endocarditis on a prosthesis, you remove the prosthesis and implant a new one. So how do you see the indications for this procedure, TAVI and TAVI, following endocarditis?
Let's do our program.
ابو طلال سامعنا؟
سامعك طال عمرك.
Well, I think يعني this case طبعا he had his first TAVI when he was 69 years old. I don't know exactly what was his surgical risk at that time. I would think that now, of course, he has an STS score of 7. He is at a higher risk for surgery, and there is a clear indication to go ahead with a TAV and TAV.
Great. So now, obviously, Hussein, when we're dealing with a TAV and FAV, several other considerations come up that are unique to a TAV and TAV procedure. Please enlighten us on the risk assessment you did, especially since the first TAVI valve was a tall stented valve, regarding the risk of sinus sequestration, the risk of the height of the neoskirt, the valve to coronary distance, and this information that is important for us to assess the risk of placing a second TAVI valve in this previously deployed Evolute valve, which is obviously a tall stented valve.
I think there are many factors or several factors you have to consider when you plan to do valve and valve. I think the most important is the consideration when you do the first valve, especially when in somebody who has long life expectancy. Somebody in the 60s, you expect them to live at least 10 to 15 years. So I believe you should really go for a short frame valve rather than a long frame valve for an easier future valve and valve. If we look at the CT of this patient, first you see that the valve is well deployed, it's not low. Can we go to the next please slide? Okay, it's well below the annulus as you see. It's well opposed. And you see significant leaflet calcium in the sinuses, but we see good space around 5 to 6 millimeters between the valve and the coronary.
Hussein, let them enlarge the angiogram.
If you could put the angiogram on the main screen instead of the slides.
Yeah, we are seeing you. We see your beautiful lab and your elegant team. We are really proud of you, Dr. Hussein. Inshallah, that's going to be a great live transmission. So, show us the injection of the aortogram, please.
Do you see our screen?
Yes.
Yes.
Yeah, it is. Yeah. So the valve at least like almost more than 3/4 of the ferrous diamond below the valve. So it's like almost probably 10 or 11 millimeter below the annulus.
Actually, now that's an important point, Dr. Kashkari, because when you're doing a valve-in-valve in an Evolute valve, the higher the initial implant, the greater the risks become of the neoskirt causing sinus sequestration or a problem. So the fact that the first valve was implanted relatively low actually makes for a safer procedure this time around.
Yeah. So, Dr. Hussein, it's clearly from your elegant engagement, you have a commissural alignment, and I can see the seat up. It's on the inner curvature. So there is a commissural alignment. I'm not worried about it, and the valve is deep. I would like to know by CT how many millimeter of the valve below the annulus.
It's around 6 millimeters.
Oh, that's great. That's great. So the skirt is about 14 or 15 or 16. So if you have 10
The skirt
millimeter
is
only
13.
above the annulus.
Just to clarify to the audience why that is important. If this was a very high implant, let's say it's 0, with the neoskirt length, you may then, and if you had a low sinus height, you then run the risk of sinus sequestration. But because it's low, 6-7 millimeters below the annular, the height of the skirt now 16 minus 6 or minus 7 makes the neoskirt only going to be 9 to 10 millimeters above the annulus. So you should be quite safe there.
Do you agree with our conversation, Dr. Abu Talal?
Of course, I agree. You know, the skirt height is around 13 millimeters. The commissural height is around 26, as you see in the slide. And the sinotubular junction height is around 23 to 24. So we are a little bit safe. The distance between the valve and the coronary is around 6 millimeters. So
Excellent.
again, the risk of coronary obstruction should be low. So now considering the native annulus of 700 and the current measurement with the undersized valve of around 500, what valve size do you recommend?
Interesting. So if you allow me, now gonna be so the valve choice now for valve and valve, definitely it will be Dr. Muhammad Atabi is having questions. Sorry. Yeah, go ahead, Doctor.
Hussein, nice case, a beautiful team. I trust you guys. But I wanted to confirm that the skirt is only 13, it's not 16.
Yeah,
so
13
that's
and
very
6.
important. Yeah.
The valve choice, Dr. Hussein, I don't know what valve you're gonna choose, but definitely the less bulky, the better hemodynamic balloon expandable should be used in this patient, and I'm quite sure you will have a single-digit gradient. And that's the beauty of implanting. That's the beauty of implanting evolute first.
No, the beauty is to have a short frame first, then you can implant.
I'm just joking with you.
Anyway, our plan is to choose a short frame valve, and we'll go with the octacore because it's short frame. It has and it has different sizes that fits different patients. Probably we are more liberal on the sizes when it comes to octacore.
So which short frame valve have you decided on? MyVal or an Edwards?
We'll go for MyVal octacore.
Yeah.
Okay.
So why MyVal, Dr. Hussein? Why MyVal?
You want the truth or the science?
No, I want the landmark trials input. Better hemodynamic, less bulky. That's the reason.
Sorry, I can't hear you.
I mean, like.
If you come close to the mic.
Yeah, from the landmark trial, we know that the MyVal have better hemodynamic. I would choose MyVal in this case for sure.
I think, if you think of valve technology, I believe MyVal is as equivalent as to Edward or any other balloon expandable valve. We've been using MyVal for the last 4 years. It's an excellent valve, excellent hemodynamics. We had no problems with it. And I think the evidence from trials and registries really supports the use of MyVal in these patients with good durability, good hemodynamics. And the good thing about it is it's user-friendly. It's easy to use. It's very flexible.
Yeah, I agree, but I don't think we can quote trials when we're doing a TAV in TAV. That's a totally literature-free zone. Yeah, but I do agree with the MyVal. The MyVal certainly does have some advantages regarding the flexibility in sizing, the fact that you can commissurally alignment is the only balloon expandable valve which you can commissurally align. The Edwards you cannot, and the fact that also, should you run into issues, the my valve is again the only balloon expandable valve that you can withdraw as well, that you can also withdraw. So that's another advantage. The only disadvantage I have seen with the my valve is the sheath, and I hope they can improve on that.
Yes, Abu Talal, thank you very much for bringing.
The sheath.
Abu Talal,
Yeah,
you
we
hear
have
me?
the new sheath. We have the new sheath now without the balloon at the top. There's no leak and there's no bleeding from the sheath. I believe we have many advantages, but we are not here to talk about the advantages and disadvantages of valves. So let's go to the sizing, please. Our plan is to use a 29 valve. So what's your recommendation? And the reason is to seal the annulus, to seal the paravalvular leak. We have large sinuses of around 30,
Yeah.
34,
So,
and
yeah.
good height for the sinus-tubular junction.
Yeah. So honestly, I will depend on two things, but the CT for me is in here is very important. What is the diameter of the evolute at the level of the annulus measured by CT? I will use this as the reference.
And if you have paravalvular leak, will you change your consideration?
If the patient having paravalvular leak, I think pushing more the metal of and the leaflet of the evolute outside further, it will decrease the paravalvular leak.
It will increase?
It decrease. It will help.
Decrease, yeah. So you know, our choice was 29 valve because he has some moderate paravalvular leak. And we're going to go a little bit low. We will not go above node 4, around node 4, hopefully. We'll avoid the coronaries since the sinuses are big. So our choice is 29.
So do you think, if you're choosing a 29 my valve, do you think the original valve was undersized then? Because generally, a size 29 evolute would correspond to a size 26 balloon expandable Edwards valve.
Yeah, you know, the native annulus in the first end, you go back to the CT, please, the first slide, go back. It was 700.
Abu Talal, Abdullah speaking.
Yes, this one.
Thank you very much.
It was around 680, and the sinuses were really large.
So the initial evolute implant must have been undersized then. That would explain the paravalvular leak as well.
What is the 23 or 26?
If you look at
The evolute is a 29. 29 evolute.
29.
Abu Talal, I have a question. Do you hear me?
Yes, I can.
Yes, thank you very much for bringing such a complex case in such a meeting. I just want to know, what is your concern? MashaAllah, you and your team have a huge experience in doing TAVI for a long time. What is your concern in doing a TAVI in TAVI compared to a native TAVI?
Actually, you know, the first concern is coronary obstruction, and it's the most serious complication. The good news is that we have large sinuses of 34. We have good coronary height of around 15 millimeters. We have a very good height of sinus-tubular junction. And the skirt of 13 is of the evolute valve is well below the sinus-tubular junction. The deployment is good. It's a little bit lowish, which is acceptable. So we have all the markers are positive, and probably the risk of coronary obstruction is low.
Very good.
The second is sinus sequestration, and again, sequestration, I believe, is we are at very low risk because of the large sinuses. Even if we take 29 valve, it will not sequestrate 34 sinuses. You know, if you see there are bulky calcifications, go to your CT, please. There are bulky calcifications in both sides. So we are a little bit concerned if we emphasize that we could have some risk of annular rupture.
Okay, that's, I think, good. If you don't mind to proceed with the procedure, Abu Talal.
بس حسين دكتور حسين.
Yeah.
But you see, the point is the overhang. You can't go lower down because of that, of the concern of the sequestration. but the overhang, the Medtronic leaflet overhang, so you have to make a reasonable adjustment not to have overhang of the leaflet.
Yeah. So that's an amazing comment. But there is a nice paper, Dr. Muhammad Al-Atabi. The overhang, whatever the overhang you leave or you eliminate, it will not affect the hemodynamic according to a large number of patients in paper. So the overhang, will not worry about it. The most important thing for me is how much metal and native tissue gonna be pushed outside. Like imagine there is at least an additional 1 or 2 millimeter of the metal, and the tissue itself will be sequestered toward the annulus. So for me, 29 is good as far the sinuses allow you, and the diameter is high. And I'm quite sure you did all this measure, sir.
Agree.
I think always you should consider the mechanism of failure of the valve. The mechanism here is endocarditis and valve breakage. So the native leaflets are still viable. If the mechanism of is stenosis, yes, I think Muhammad's comment is very valid. Because even if you dilate it with the balloon, it will come back within a few months. So the good news is that the mechanism here is aortic regurg, since it's very early failure. And we are not really worried much about overhanging, because if we go high, we will probably occlude the sinuses. So we prefer some leaflets overhanging rather than sinus sequestration.
Okay, maybe we should go ahead and proceed with the procedure for now.
Yeah, you go ahead and continue the procedure, Dr. Hussein.
Yes, sir.
My concern, I'm a surgeon, and my concern is here the underlying causes infective endocarditis. As in surgery, we debride and remove all tissue infected. So do you think this valve, there is no risk for deterioration again?
That was the
This
first
variable
question
burning?
I addressed to Dr. Adil as a surgeon, because the surgical dictum is remove and debride, but apparently this is a high-risk patient who's treated some time ago for endocarditis, and cultures are currently negative, and they feel they can safely proceed. Go ahead,
he's
Hussein.
almost 18 months after, he's 18 months after the endocarditis. So really the risk of still having an active endocarditis is almost nil. His cultures are negative, his inflammatory screening is negative. We are waiting for the valve to be ready because we were waiting for your approval for the 29 valve. I
Seen
think
by dental and clear and also the surgery add to this is replacement of the aorta. Long frame, they have to replace the aorta, and he may end with ventas.
I see you
I
have your.
believe we have to be.
I see you already have your wire in the left ventricle. Any tips or tricks when you're crossing a tall stented TAVI valve like this, so you make sure that you are through the valve, not through struts and then through the valve?
Actually, we never cross with the wire like the way we cross with the native valve. We cross always with the catheter. And we choose a small catheter, 5-inch big tail, for example.
Absolutely.
Just to make sure we will not go through the struts, and then we exchange the wire with the big tail.
Absolutely.
I believe it's very important not to use a straight wire, because you never know where you are, especially with a 2D angiogram.
Exactly, that was the point I was trying to convey.
Yeah. So always use a big tail rather than a straight catheter or a straight wire.
So the beauty of now you having the valve is now you don't need to go for cusp overlap view or coplanar view. Is just to go where in any view that you eliminate completely the parallax, and you can see the valve nicely, so you can park your valve easily, and you don't do all that hassle. Dr. Hussein, what we want from you kindly to proceed and show us the advancement and implantation of the valve. Allah ta'ala fi umrak.
So Hussein, the lower level of the MI valve, you're going to implant it at which node level?
we'll go outflow to, inflow to inflow. So we'll try to be below the node 4 as much as we can to avoid the sinus sequestration. It depends, of course, the nodes is easy to see
Absolutely.
on
I will.
papers, but it's difficult to see.
I agree with you. I will park the lower part with the lower frame of evolute. If it is truly 6 millimeter below, so your Mayval skirt will be in a good position without doing like a lot of elimination of overhanging.
But these valves, they shorten usually from below. So
Yeah.
our landmark will be the sinuses, sinutubular junctions, and the coronaries. So the upper part of the valve will be below the coronaries as much as we can, because from down the valve will shorten and will hopefully come up to the inflow.
Yeah. So I agree with you, but I usually depend exactly, like what is the final diameter of the Mayval when it is implanted. So I calculate, from the inflow, how many millimeter. For example, if it is when it's fully expanded, let's say it's 20. So I make sure that from the inflow, what is like 10 millimeter in relation to the inflow. It's just like rough estimation. Because I found difficult if to park it perfectly if you start from like where you fix the as you said, like at the level of the for example sinutubular junction. It's very difficult to know where to stop down below. So I usually try to center it as much as I can according to the final diameter of the inflated balloon. A bit calculation, like more calculation.
The good thing about octacore is that it has a second marker below the central marker of the balloon, and that marker can really help in placement of the valve. And I just really would like to congratulate Abha Hospital for the good work. This valve deployment is really fantastic. It was done in Abha, and
Yeah.
it's really a very good position and very good deployment.
Yeah. So go ahead, Dr. Hussein.
Yalla, Majid. You said 4 minutes, and it's 10 minutes now to prepare the valve.
Go ahead. We are watching. If you stay 1 hour, we are with you. But we are enjoying.
تحرجنا يا وائل انت. بسم الله.
شايل لك وردة زرقاء في يدي ان شاء الله نديك اياها في الاخير دكتور.
لا انا ما ابغى زرقاء، ابغى شيء ثاني. روح لا. We'll go for slow deployment so that we can position the valve. And I think many people, they go for fast deployment because they are worried about the hemodynamics. And I think we should not be worried much about the hemodynamics. We should be worried about the position of the valve. You can see our screen, yeah?
Yes. Please go ahead.
Can you just focus on the angio and enlarge it a little bit?
Camera guy.
Full screen.
Okay, please rotate so that we don't touch the valve. Yeah, go. Okay, wait. All right. Now it's fine because we were pushing the other valve. Yes, go. Push the wire a little bit. Okay, wait. Let's manipulate the wire and rotate more, please. Rotate more. Rotate as much as you can. Doctor. Okay.
Excellent. So the pullback technique now. So if there was a calcified valve, for sure you will pre-dilate, but now the mechanism, as you said, is just regurg. Can you zoom, please, on the valve? Just zoom on the valve, guys.
Zoom.
Increase the magnification. In
Increase
your
the
fluoroscopy.
magnification.
Abu Talal, what is your landmark in positioning, Abu Talal?
That's better.
Our
Thank you.
landmark will be, I'm depending on the sinus is up. Now we'll go down with the big tail. Go down with the big tail, please. Okay, and go down with the valve because it will shorten from down. It's a short frame valve.
Yeah.
I need the marker, the balloon, the big marker below the valve. Down, 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 down. Okay. Now you see there's a two markers, the balloon, the one in the middle of the balloon, and the second marker. We will keep it at the edge of the previous valve because it will shorten from down. Oh,
Yeah.
Okay.
Dr. Hussein,
yes. What do you think of this position now?
first of all, you don't have any parallax in the evolute valve. That's a nice, view. There is, you are like truly having no parallax in the previous valve. Is it like واضح عندك دكتور حسين؟
Yeah. There's no parallax,
Yeah.
fortunately. And,
Yeah.
and you see now, if we go down with the
I think your valve is a little too low there.
Yeah, and there is no parallax in the May valve. I can see the radiolucent line very clearly. So
now you see the position is really good. It will shorten from down.
Yeah.
And it will align with our valve. I believe
would-
this position is really good.
I would
Go ahead,
pull
Wa'il.
little bit. I would pull little bit because the radial force, like you know, the waist of the evolute, it's gonna cause some gradient. The waist of the evolute itself. I would pull little bit up.
I agree. I think
Okay,
you're a little
let's
too
move it
low
a
there.
little
I think you need to pull it
I
أبو
agree.
طلال شوية.
Pull up حسين شوي.
Okay, that's too much. No, that's too much.
Yeah, this
Okay, what
better.
about now?
I think this is better, yes.
هو وائل اللي يعترض. وائل, what do you think?
Well,
I still think it's a little too low
Do you
there.
like this position?
I would pull little bit, Dr. Hussein.
back.
I would pull back
No,
little bit.
then it will be a little bit high.
No, don't worry because
We are already inside.
yeah, do
This-
an
this-
injection. Do an injection here.
I think this is good. This is good.
No, I'm not really happy. It's too high.
see-
it will shorten from down.
No,
and it will
push it.
shorten at least 5 millimeters. While
Yeah,
down.
push it a little bit in, and because the left main, look, the left
Okay,
main
now,
is
now it's good.
okay. Do an injection,
the
please.
marker. While look at the large marker. This large marker should be at the edge of the other valve, and now I believe it's in a very good position.
That's an excellent. Now it's better than before. Before it was way below down.
بركاتك يا باشا.
Yes.
يلا, let's break
Yeah.
that.
Now we
100, please.
Now we will take out while from you to focus on the case. تعال وائل, just-
Okay, we'll go for slow inflation. Go.
Don't forget to pace.
Pace,
Go. All the way. اسحب بندر.
guys, all the way up.
اسحب شوية. Pull back. Okay, that's fine. Go all the way. Oh. Okay, hold.
It's okay.
Okay. Yeah, stop this. Okay.
It's okay.
Okay, now I think we are in a surgical side now. And I believe he has to go to surgery.
I think
This is what we were
Is,
trying to
is-
avoid.
How is the patient, Dr. Abu Talal? Is okay?
No, he's stable. Pressure is
It's
fine.
stable. خلاص, pressure is okay. I'd say safe, I think, to call surgeon now. I think. Yeah.
Okay, call the surgeons, please.
Yes. Okay. So tell us, Abu Talal, what do you think the reason for this?
Well, I think we were not holding the valve very well, and we were not really pulling back with good force. Or maybe we are oversized, and it's like a watermelon seeding.
I would just add to make sure don't pull the wire, leave it until the patient go to surgery, so it doesn't flip
Oh yeah, definitely.
within the LV.
No, it will not migrate because the
anyway, sometimes it's good to see complications rather than success. I think this is where we learn. When you say somebody has experience, it means he had made a lot of complications and he saw everything. It does not mean he's good. It's the other way around.
Yeah,
Don't
it
worry
happened.
about
He has
that.
seen
It
a lot
happened to
of
all of us,
complications.
Dr. Hussein. Out of 7 cases, I had one like this, similar. Like it slipped inside. It's part of our job and business. So the surgeon now is on board. It's well known, like procedure complication that can happen. يعني.
All right. Any final comments?
Dr.
Thank you
Adil.
very much. First of all, thank you very much, Abu
What do we
Talal.
learn from this case?
This is a very complex case. Of course, with the severe AI, with the endocarditis, with all of that. So thank you very much for showing us this case, to have the courage bravery and to show such a very high risk case. This is a complication that is not surprising because of the complexity of the case. And thank you for all your team,
Incubate him,
Abu
please.
Talal. شكرا لك.
يعطيكم العافية أبو طلال. Thank you very
يعطيكم
much.
العافية يا سيدي، الله يحفظكم.
يعطيكم العافية إن شاء
الله
الله.
يعافيك.
Thank you very much.